The
your
lungs.
breast.
Lungs and cords, right?
So if they're tracking goes to the lung,
Uh-huh.
you need the whole lung volume.
Okay. So I would say view patient.
Mm-hmm.
And then I would give the ID of whatever, right?
Yep.
And then
And one thing before we leave, you can always do what I call like a dry run. If the patient's on an angle and I would bring them into the gantry, kind of I guess what would you call it, to see if you have clearance.
And then I would say that we are doing chest.
Yeah. Too big. Oh, did give you a choice.
You didn't click on the anatomy, you just clicked
Oh,
chest.
okay. That was fine.
Oh, okay. And then
What if, can I ask you a question? What if we were doing, including the super flap? How far out do you think?
we're doing just yeah.
Oh, I'd say more than that.
Some doctors really have a high suit border on their super flap. So, but you'd want to know that before.
Yeah.
And if you had any doubt, just do more.
I would ask the doctor, how high, what level, what's cervical vertebrae.
Would it be smart, I mean, even if you're not doing a super clap, to probably just include it anyways, because they might change it later on in
Because
the
they
treatment?
can change it, and that's happened to me. They decide they want to treat the super flap,
Right.
and they told me they just are going to do a tangent. And then, if you didn't scan high enough, then you have to call the patient back.
Redo the whole thing.
So it's safer to do a few extra slices now. One other thing is if you're treating a left or right super flap, the doctor may want to turn the head left or right.
Right.
Do you know why they do that?
To get out of the field.
They soft this out. And so, do you want to sim them in that position?
Yeah.
Yes.
And I confirm.
It's gonna prompt you.
And then we'll start my scan.
She just coughed, so now what are we gonna do? Is that okay?
Yeah, it's okay. Yeah.
Coughing. As long as they don't have coughing fit. But if you drop your arms to cover it up. It kind of depends on, well, I would go check to make sure they're still on the lungs. Well, you wouldn't be able to tell, but you could kind of at least look to see if they're rotating. It's your call. You know, how much did you see them move? If you didn't,
So
if
the
you were
middle
looking
button,
down
left and right,
and
should
then
show
you
the
looked
anatomy.
up, you noticed, then I would just go check.
You should speak everything out loud, Jake.
Yeah, Jake. You have to walk us through this.
Middle button, right to left. Okay.
I would always check for soft tissue on a
Soft.
breast. Because what if you cut off breast tissue? Then you're going to have to actually offset the patient in that case, which is really tricky. But it has to be done because you've got to have all that breast tissue.
Do they have to have a mastectomy then?
A lot of times what we'll do if the patients are really big and they're too wide to get on the scan, what we might do is bring one arm down, the opposite arm, and then scoot them over farther so we can do it.
Oh, okay.
Okay, Jake.
All right.
I think you're good, yeah.
Next series, I think, right? Or an exam, right?
Yeah, next series.
Oh, next
Yeah,
series.
and on the
They're
scouts,
axis.
you always kind of want to visualize. Do they look really crooked?
Oh, there you go. There are your parameters.
So Jake, you just hit next series?
Yes.
Okay.
Say it, Jake.
I hit
Do they
next
look
series.
rotated? Anything like that?
Did you say we're doing the super clap on this one?
No.
What would be the difference?
Would be more soup.
superior
Yeah.
anatomy.
But you would just say we probably want to do it anyways, no matter what.
Take it
Do
all.
you
Jake,
always
take
go
it all.
higher on?
No.
Unless you're certain that it's going to
Yeah.
be tangents.
If I'm pretty sure it's tangents, I won't
Yeah.
go that high. But
And you said to include the whole lung volume,
Do
right?
you do that page up to flip between?
Oh yeah. If you do page up or page down, it's easier to see the apex of the lung. And then again, I just look to see how straight the patient is. Sometimes they look crooked, but it's just their spine.
Mhm.
Their scoliosis.
Mhm.
So in that case, you can't just use the spine. You kind of have to look.
Do you think that's a good range between?
A little bit
I
higher.
would go a little higher. Yeah.
Okay.
so here's the view where you want to make sure you've got all the breast on. So there's nothing there. So you're good there. You want to sometimes, especially when the patients get big, and say so we had to put the left arm down and scoot the patient over. Well, then we're obviously not going to get the left side on. But you have to envision, well, where's the calculated volume? Because typically we want all the body, but you're not going to get all the body sometimes. And so
Mhm.
we're calculating through here and part of the lung. So as long as we've got all that calculation plane in there, we'll be fine.
Okay.
Sometimes on the patients that are really big, we'll cut off the affected side. And what I'll do is I'll look at that and say, well, I'll probably ship it over here so I can see the skin rendering view. I'll go ahead and do the scan. I'll say, well, I've got all the breast on, but I'm missing a little bit of this arm up here. Now I know that's in there, but there's really not much I can do about it. So maybe you say, bring your dosimetrist back here and say, look, I got all the breast on there, I got all the side here, I got the anterior and the posterior part where the beam's in it, and the central axis is good, my SSDs are good. I'm missing a little bit of the fleshy arm up here that's going to be in there. Say, well, we can work around that, no big deal.
Okay.
So here's again where you really want to check and make sure that you've got a good calculator.
So if that was the case, would you're talking about your border can be coming in like right about there?
Yeah.
Okay.
So a quick question about that, I mean, it's silly, but so if you move them over on the table, your laser is now going to be off to the side, right? Do you just adjust your laser so it's back at the?
Well, yeah, we do go ahead and remark the patient. Now for us, how
You
we
think
do
that
things a
median
little bit different. Well, we do things a little different, and so I don't really, I'm not really concerned with where my zero line is on her breast, because what we do is the doctor's going to come in and draw on a volume, and we'll completely wire up that volume. Okay, and so we'll put a midline wire and we'll put a wire on the volume, and so here's my zero line, and I always tattoo underneath the wires at 0. So my laser might be here, but I'm going to tattoo under here, and my dosimetrist knows that our tattoos are always under there. So if you're going to scan from 0 and pick a 0 line, then yeah, if you moved your patient in between your scout, you'd stop everything, remark your patient on your 0, and then start over again. So if you had to move them, and so anything other than, like if it's a pelvis, a large pelvis, and I've got to move them because I'm not getting everything, then yeah, I take off my old marks, put new marks on, re-zero and everything. So basically starting over once you move the patient. Now this is really going to
You
confuse
always-
people in my Spanish class when I take these pictures, so I'm going to have to take that off.
But you would, sorry, I'm still.
That's all right.
Would you actually move? So when you move your patient over, your laser is off to the side. You don't remark them there. You move your lasers back to their.
Right, lasers are always back to 0 or wherever the midline is.
But this laser, you can't move.
Right, because it's
And it's
at
all
0,
right.
it's fixed.
Okay.
So
Yeah.
if you have if we lined them up the first time and our laser was right down the middle,